I am absolutely delighted this afternoon to be joined by Dr. Deepak Joshi. As many of you will have heard the name or might even be at King's Hospital and under Deepak Joshi anyway. But Dr. Joshi is a transplant hepatologist at King's College Hospital, London, and is the lead for Pancreatico-Biliary medicine at that hospital. He's also one of the leading doctors of, PSC in the UK too. These are very popular sessions. You can ask any of your questions on PSC. And we always know there's a lot of questions, but just to bear in mind, I always mention this and it gets a bit boring for you to listen to, but just to bear in mind that Dr. Joshi will do his best to answer all of the questions, but won't be able to give individual medical advice. Please put your questions in the comment section and we'll get to as many as we possibly can, but keep them quite short if you can, so I can take as many as possible. As always, I'm sure you will join me in thanking Dr. Joshi for joining us this afternoon. He was just talking about dropping his kids off somewhere, going for a run. He is a very busy man with obviously a very active and busy work life, but also family life too. So we are very, very grateful, Dr. Joshi, for your time this afternoon. I have a couple of questions that I've had beforehand, so we will start with those. One is from a mother. My son was diagnosed at the age of 9 with PSC, and she's asking, how common is it to be diagnosed at this age? And does that have any bearing on how poorly he might get in the future? So the age. She's got a follow-up question to that. He's been having Urso and Pentasa since his diagnosis. That was 20 years ago. Is that a bad thing to have these drugs over such a long period of time?
So first of all, thank you for the very kind invite. I'm hugely grateful for the opportunity and also for all the hard work that the PSC support do. So I always feel slightly embarrassed that I'm the expert, but I'm just here to offer, some advice and sort of listen and sort of try and answer questions as best as I can. So thank you, first of all. So going to the question, I think overall, we all know this PSC is a rare diagnosis, in the general population. In a 9-year-old, there are other causes of PSC type sort of illnesses, but it's not uncommon, and we see this at King's. We have a big pediatric service, we have a young adult service, and then we have the sort of full-blown adult service as well. So in those services, no, it's not that uncommon. It sounds like they were diagnosed with colitis, so they're on Pentasa, and then obviously they're on a bit of a sodium acid as well. I think it's fair to say that the natural history from pediatrics, the diagnosis of pediatrics, to adults, we're learning more about it as we go forward. Whether this will, in some cases it can change a little bit. Like some people, when they're first diagnosed, they have sort of an autoimmune hepatitis overlap. Doesn't sound like it in this case. But I think it's very hard to predict the future, other than you need good follow-up. The colitis needs to be optimized and treated as best as possible. And, only with the test of time, we'll know which way things will go. I think having a child or any child with any illness, you sort of worry about their future, etc. But I think, we now all of a sudden have different drugs which we're using in clinical trials, which, something will come through. I'm a positive person, will come through to mainline services. So, nobody wants any child or any individual to be unwell, but hopefully within PSC, there will be something we'll be able to offer, which we know won't cure the disease, but we might be able to keep it in remission and control it. So only time will tell.
Okay, thank you so much for that. We have some questions on the chat, which I'll take a couple of those now. How many people have a transplant and then have no difficulties or setbacks within the first 6 months? Do we have a figure for that? Or does everyone have something go wrong, no matter how small?
So I think, transplant, liver transplant is a big operation. Okay, so at King's, when I'm on the wards, if I meet people, it doesn't matter what disease they were transplanted for, I will say you're going to be in hospital usually for a minimum of 2 weeks. And there may be days where there are slight setbacks. So, for example, the blood tests may not be all sort of settling down as we want, might need a liver biopsy. But these are all things that we anticipate. And I always say this to my patients is that, we've seen this before. Nothing usually that is going on we haven't seen before. We know how to manage it. We have sort of management plans for all these scenarios, and everybody's individualistic. One person might be in for hospital for 15 days, one person might be 10 days, but we just take our time. There's no rush. So I think 6 months, when you say things go wrong, you have to be specific. There will be times when liver blood tests will jump up. You might need a liver biopsy. We might need to give you high dose steroids. We might need to do an MRI scan. We might need to do an ERCP or a PTC. But these are not necessarily problems, but they are part and parcel of a post-transplant course, which in any of the centres within the UK, they are well versed in managing and looking after those individuals.
Okay, thanks very much for that. So I have another question. My son is due to have an ERCP in a couple of weeks using balloon dilation. Should this procedure improve his fatigue? We know that fatigue is a really big problem in PSC.
Yeah. So I perform ERCP. So the indication, what it sounds like, is that there is a high-grade stricture. So there's a stricture that we think is either causing itch or a change in the liver blood tests and or jaundice. And by intervening, we would want to assess that stricture. So we might do some brushings. We put a little brush up and down and catch the cells. And then we tend to balloon dilate to open that area up. If your if your son is what's the word, very jaundiced, then if the jaundice is relieved, then yes, the fatigue can get better. But again, it's how they respond. So I think only time will tell for that as well.
Okay, thank you so much for that. I have a question that was sent to me beforehand. I was diagnosed with PSC in 2007, but had symptoms for some years before this. From memory, the consultant who diagnosed me told me to contact him if my CA 199 number ever went over 90. In 2015, it was 191. It is now 147, plus I have gallstones. At what number would you recommend an ERCP?
Okay, so CA 199, it is a tumor marker. It's not very specific, so we use it in individuals with potential cancer of the pancreas or potentially cancer of the bile duct. Now, CA 99 can go up for different reasons. If you've had cholangitis, if you're jaundiced, what I would say, it's not that you need an ERCP necessarily. You need to engage with your consultant or your team. You need some imaging, usually a liver MRI and an MRCP, which will look at the bile ducts and, plus or minus a CT scan. So I wouldn't go on the absolute value of the CA19-9, but it's more looking at the liver as a whole, the bile ducts as a whole, and making sure that's being reassessed.
So making sure that they do engage with their healthcare professionals. Yeah. Okay. Another question's come on the chat. And we know that, well, there's no, we talk often about diet and fitness, don't we, with patients with PSC. So this question is, I have recently been diagnosed with crossover PSC with my autoimmune hepatitis, found that the itch comes on after eating fatty foods, for example, curry and pizza, and comes less when I train hard, weightlift, rugby, CrossFit. Are these grounded in anything medical or just random correlations?
I think there is probably a science behind it, but I don't think I can give you the science. I think, when we exercise, when we do the things that we enjoy, and it sounds like this individual likes exercise, you do get a bit of a sort of a buzz, an endorphin hit, you feel good about yourself. Yeah. And psychologically, I think when you eat all the bad stuff, which obviously tastes very good, you sort of, you feel a bit guilty as well. So there's probably a bit of a psychological aspect to that. Fatty foods can sometimes, put more pressure on not only through the gallbladder or the liver, but sort of your digestive tract as a whole. And maybe, there may be reasons why you feel a little bit worse, but no, I can't give you the exact signs, but everybody is different. And I think if you can find things that make you feel good, you should do them. And if you can find things that make you feel not so good, then you should try and avoid them if best possible.
Okay, thank you for that. So we have another question on the chat. Can you turn back PSC through steroid tablet treatments?
So PSC, by definition, is a non-steroid responsive disease. Otherwise, we would prescribe steroids and other immunosuppression for all patients with PSC. Now, there are certainly a group of patients who may have a more inflammatory type disease, and this again tends to occur in younger adults or children, where if you give them steroids and immunosuppression, it can improve to an extent. So the answer to that in truth is no, but again, it depends your age, time of diagnosis, and other parameters, which may consider your consultant, your team, to give you a course of steroids, but by and large, the answer is no.
Thank you. Thanks very much. So this next question is probably you've got possibly quite a long answer for, but so the question is, which clinical trials are running at the moment in the UK?
So I'm going to default to the PSC support website.
Yeah,
there are a number of studies. I can tell you what we're running at King's. Obviously, I don't know off the top of my head about all the other centres, but we have 2 studies which are looking at anti-itch. So one of them is the VISTA study using an IBAT inhibitor, and the other one is the Pacific study, which is looking at another mechanism of itch. So we have those 2 studies. We also have the SPRING study, which is looking at a monoclonal antibody in individuals with sort of very little scarring. And then we will eventually open, hopefully in the next couple of months, the Fargo study, which is the fecal transplant study, which is originated in Birmingham, looking at IBD and PSC. So they're the sort of 4 studies we're running. But look on the website, there's probably more up-to-date information than I can provide you.
We certainly do have all of the clinical trials that are running in this country on our website, so please do look at those. What sort of new treatments, clinical trials, are coming to the fore at the moment? Is there anything that you know that's in the offing? Are there any for crossover PSC?
So there are a number of studies that are looking at different pathways, sort of looking at different molecules. I can't necessarily elaborate about it. There are also some studies which are hoping to look at, for example, what we do at the time of ERCP as well. So I think one thing I can promise you, certainly in the UK, we have the UK PSC group, which are very active, which are always trying to think of different ways of assessing disease, managing disease in both young adults and adults. And also at a sort of international level as well, there is something called the International PSC Group, which also is constantly trying to look at ways to improve outcomes. So in a roundabout way, yeah, there's lots coming, but no specifics at the moment.
Thank you for that. So I have a question that was sent again beforehand. Son has had PSC for 20 years, been generally well, but he's had bouts of colitis over the years, and but he's had bouts. So he's been generally well, sorry, but he's had bouts of colitis over the years. However, the last 4 years, he has been admitted to hospital with severe flare-ups. As a mother, I'm constantly worried that his condition will slowly start to worsen as he gets older. We recently asked if he could be referred to Nottingham Queen's Med, as they do specialise in this condition, as opposed to him staying at the Lincoln County. Have I done the right thing? All mothers want to know that. What are the signs about that his condition is worsening? His new consultant has also requested a FibroScan. What would this show, please?
Okay, so I think I'll start with the last bit. So FibroScan, first of all, is a special kind of ultrasound scan. It's a non-invasive way of assessing how much scarring there is in the liver. It can also tell you how much fat there is in the liver. So as we know, any cause of liver disease causes scarring, and eventually scarring can progress to advanced scarring, and then one has cirrhosis. So I think a FibroScan would be very sensible. You know, personally, and I say this as a parent, not as a clinician, I think if you are ever unhappy with the care that you're receiving for your child, your mother, your brother, your sister, your father, then, you know, if you are in a smaller unit, then you should not feel guilty about asking to be referred to the local bigger centre. So it sounds like Nottingham is the local centre. There's lots of good individuals at Nottingham. I know Martin James, who sort of has an interest in this area. So by all means, I don't think you should feel shy. And as a clinician, if I'm ever asked to refer somebody to another service, you know, I don't feel sort of, you know, one's ego shouldn't get in the way, and you should say, yep, that's fine, it's your choice, I will write the letter or refer you on. You know, I think if the colitis is not sort of well controlled, it can have an impact, obviously, on the liver. And one of the things we always try and do with all our patients, given that we have no treatments for PSC, is we try and optimize all the things around it, and IBD is so important.
You know, I think that's really good to know that you wouldn't feel hurt. I think people think that their doctor, because they've built up a relationship with them, they don't want to be referred on because that doctor would feel hurt. And I think people are so nice, they don't want to do that. So that's very interesting.
Yeah, I think, you know, I obviously I sit in the bigger centers, so it's very rare that I'm asked. But at the same time, you know, if I feel within King's there's somebody who's better at managing a certain aspect of somebody's, you know, care, you know, I will refer them, because, you know, we can't be good at everything. And if there are other things which people can give a little bit more time and effort for, then why not? You know, I think the rewards are huge for that, for the individual.
Yeah, great. Thank you for that. So what is the latest news, and I hope I pronounce this right, on macrophages and fibrates in relation to PSC?
So I think so fibrates are now recommended for first line treatment of itch in PSC. So these were on the background of the EASL, so the European guidelines, which were published last year in 2022. So you know, what we tend to do at King's, if somebody develops itch, we obviously will talk to them about a clinical trial. Does it work for them? Does it suit their, you know, day-to-day lifestyle, or shall we start something for itch? So fibrates are very cheap, very few side effects, designed as something for treatment of, you know, your triglycerides or your lipid profile in your blood, and, you know, very few side effects. The main one is that it can cause your kidney function to jump up a little bit. So we use it quite a lot. So, you know, and also there is some data, albeit small numbers, from France and the rest of the world, where maybe there is a mechanistic benefit as well. But we tend to prescribe it for itch at the moment as opposed to anything else.
Thank you for that. This question is from another mother. We do have lots of mothers coming on to these because obviously they're extremely worried about their sons or daughters. My 25-year-old was diagnosed with PSC about 18 months ago, but for about 10 years earlier had itchy legs, which is his main symptom of PSC. He's now living in London, trying not to let PSC impact his life, and he's really trying to live his best life. He's in the system of Guy's St Thomas's and seems to be getting good support. What seems to be lacking is support for his psychological state. Now, we know this is a lack in this country. His condition gets him down sometimes, as it would. Is there any specific counselling in London for PSC?
So the first thing to say is, again, I know the team at Guy's St Thomas's, they're a very good, great sort of team. So I agree. I think his PSC will be looked after. I think as a, what's the word, as a specialty, but also, you know, medicine in general in the UK, I think psychological support is very much lacking. I think, you know, funding streams are sort of pushed left, right, and centre, and the importance of the psychological impact of illness is sometimes forgotten. So there is no specific counselling, I'm afraid, in London for PSC. There are sort of psychological sort of initiatives which he'd be able to access via his GP, but nothing specifically for PSC, I'm afraid.
Can I just say here, and it's not the question that the questioner asked actually, but at our next information day, we are having a session with she's a liver, I think she's a liver transplant psychologist based in the Royal Free Hospital, but works with PSC patients all the time. And she is running 2 sessions on psychological well-being, the tools and the tools that people can use to live well with PSC. So I don't know if people would be interested in that, but we are providing that because we are very well aware that there is a lack of this psychological support for people. We wish there was more. We'll push for more, but we understand the lack of funding as well, as you mentioned. Okay, next question. Given our cancer risks, I've seen a lot of people mention that they are being seen by they are seen by a dermatologist yearly as recommended by their PSC consultant. I've had PSC for 15 years, transplanted for 9, and recurrent PSC for 4 years. Should I be pushing to see a dermatologist too?
So I think obviously this individual, Claire, you've had a transplant. So I think if we just take the PSC aspect out of it and just think about individuals who've had a transplant, the immunosuppression that we usually prescribe, which is tacrolimus based, or any of the sort of first line immunosuppressant drugs that we use, they all increase your risk of dermatological malignancies. And for a lot of our post-transplant patients, we do recommend that they're reviewed by a dermatologist on a yearly basis, and they have sort of a full body sort of look over to make sure excuse me, there's no moles, etc. So I think that's purely from a transplant perspective. Obviously, if you are on azithioprene for another reason, then that does increase your skin exposed areas as well.
You okay?
Yeah, I'm fine.
Okay. Next question. Had you finished? Sorry.
Yeah, no,
I
finished. And I finished
I don't
choking
know
as
whether
well.
whether you were going to say anything else.
No.
Is there anything in cold water therapy as a treatment? Now, I have a freezing cold shower every morning, so I do believe in the power of cold water, but not necessarily, not for treating anything, just to keep me awake and get me focused for the day. But is there anything in cold water therapy as a treatment?
Not that I'm aware of. I don't like cold showers, and that's just a
I
personal
don't particularly
choice.
like them either, but I do have them. Okay, thank you for that. Next question. I was taken off Urso a few years ago, possibly to do with UK guidelines. Now European guidelines appear to recommend its use, which we know. Should I ask to be put back on it? Is the question.
I think Urso always comes up time and time again. The data would suggest it doesn't change the natural history of the condition. It can improve your blood tests, and sometimes that can be maybe sort of important to see, but it doesn't change the sort of underlying mechanism. So I think that's personal choice. I don't start Urso sort of routinely. The other thing about Urso to remember is it's not very good for itch in PSC. It might be good in other conditions for itch, but not for PSC. So I think that's a personal choice.
Okay, thank you for that. Next question is from a mother again. My son has terrible itch and was given, I can't pronounce,
Cholestyramine.
cholestyramine, gosh, which worked well. Recently his jaundice subsided, as did his lethargy and other symptoms. He's just told me he'd stopped taking the sachets for the last few days and the itch appears to have gone too. Is it okay to use his medication ad hoc, or should it be used consistently?
So cholestyramine binds sort of bile acids and tries to sort of take them about, stop them from being reabsorbed later down in the bowel. I think if he's feeling better, and he stopped taking it, that's fine. And he can take it sort of ad hoc or as and when needed. That's not a problem.
Great. Okay. That's really good. Good. I'm sure that'll be very good for that person to hear. Is an ultrasound effective enough to detect any abnormalities or PSC progression? I've been given an ultrasound appointment instead of an MRCP. Last MRCP was 1 year ago.
So an ultrasound is good for example, looking at the shape and size of the liver, the spleen size, and also the gallbladder. So look at the gallbladder and look to see if there's any polyps. And the sort of European, American, and also the UK guidelines will say that everybody should have at least an ultrasound once a year. If you're looking at the bile ducts and looking at the pattern of stricturing or the pattern of disease, then you need an MRI scan, an MRCP. Obviously Jo has said she had her last MRCP about a year ago. I think that's reasonable, about 12 to 18 months MRI scans. And obviously that will help you understand if there's been any change or progression in the disease.
Great, thank you for that. I have a question here. I am a 63-year-old male with 7-year history of PSC and 20 years of UC. Due to persistent low WC of about 2.7 for the last 2 times 3 months, my gastro consultant has stopped the azithioprene. What are possible alternative immunosuppressions available for me, including I can't even say these words.
Monoclonal antibodies.
Monoclonal, sorry, antibodies.
Right.
They're so small, like it's just like.
So obviously the azithioprene here is it looks like it's for the colitis. Again, it's the balance of the importance of treating the colitis. So there are alternatives. So they've talked about monoclonal antibodies. You can think about infliximab or other agents as well, vedolizumab, which an anti-integrin inhibitor, which is thought in theory to be good for PSC and the bowel or the colitis as well. So I think there's lots of options. The other thing I'd say, I don't think that white cell count is that low. And again, it's about discussing that with your consultant, and it may have been that it's been lower than that, and that's why they stopped it. But you can also check the sort of therapeutic level of the azithioprene as well. And sometimes if it's the azithioprene is overcooked, and you can cut it back a bit, and it may be an option. So I think just discuss with your consultant.
Thank you, Dr. Joshi. We don't actually have any more live questions. Anybody wants to put a last question into the chat, you're very welcome to do that. I could ask a couple of questions. We know that PSC can come back after a transplant. Is there how many transplants can you have? Is there a number where you couldn't go past that?
I think one of the unmet needs personally in liver transplantation is how we try and reduce the risk of recurrence of PSC. And again, I've, along with colleagues, sort of individually and as a group, we've been talking to the pharmaceutical industry about looking at some of these agents with in patients who've had a transplant. So hopefully once we've got some good data in patients before a transplant, we can then use those similar drugs before. So there's no hard and fast rule as to how many transplants one can have. There have been individuals at King's who've had 5 or 6. But I think the thing to say is you need to understand why, are you retransplanting? So, okay, the disease can come back. But every time, sometimes the period between so the recurrence can reduce. So, it's important to make sure that that individual will benefit from another transplant as well. So it's a balance, but I don't think any center would not consider retransplanting an individual. But then there's lots of things like, comorbidities. So, do they have concurrent heart disease or other problems which may limit the appropriateness of retransplantation? But it's about having that discussion with your team.
That's good to know. And we've had a whole number of questions now being asked. So the next question is, how is the therapeutic level of azithioprene checked?
So a long time ago, when I was a trainee, I could draw you the pathway of azithioprene and its metabolism. Sadly, those memories have gone. But the thing to say about azithioprene, it's not as soon as you take it, it does not become active. It's a prodrug, so it has to be broken down. And then usually after maybe 6 to 8 weeks, it becomes active and it does the job that you need to do. So you can do a test called thioguanine nucleotides, which will tell you whether the drug is truly active. Now, we dose azithioprene in liver disease, not for PSC, but say, for example, for autoimmune hepatitis at 1 milligram per kilogram per day in the individual. Now, it's very unscientific, but it's a safe way of doing it. In inflammatory bowel disease, they can sometimes dose it as high as 2 milligrams per kilogram per day in an individual. But it's important to see what the metabolites are doing, whether it's sort of active, and whether the dose is appropriate as well. So it's usually quite easily accessed now, the thioguanine nucleotides, and you just need to, again, discuss with your team and consultants.
Thank you. So this is in relation to somebody, the questioner earlier, actually, whose son is 25 and living their best life in London. Obviously, the mum is worried. How important is it to limit alcohol with PSC?
So I think in young adults, and I would say that this individual is a young adult, you know, they have, unfortunately, a chronic illness, but you know, they shouldn't be defined by their chronic illness, and they want to live their best life. They want to do all the things a 25-year-old wants to do. So, you know, again, it would depend on the severity of their disease. So if they've got mild disease, they should drink sensibly, well below the sort of recommended limit. So in an adult, that's 14 units a week. Obviously, if they've got a more advanced disease, then you know you could argue that maybe they shouldn't drink at all. I think in an ideal world, any individual with a liver condition would not drink, but we don't live in an ideal world, and I say this to all of my patients. I think it's about being honest. It's about being open with your family, with your loved ones, telling them that you are drinking, or clinical teams as well, that you do drink alcohol, because the blood tests jump up and then, you know, I think the worst and I'm ordering this, that, the other. But if I know you're drinking, then I can put it into context as well. So I think it is about, you know, enjoying life, but you know, there is more to than just alcohol as well in living one's life. So you know, if you are going to drink well below the recommended limits.
Okay, that is often a question that pops up on these sessions, isn't it? Can liver transplant trigger pancreatitis?
I suppose the answer is yes. We've certainly seen it. Again, this is not necessarily related to PSC, but you know, sometimes the surgery itself can trigger it. Sometimes the medications that we use after transplant, they're sort of very rarely associated with pancreatitis, but can cause it as well. So, for example, steroids can cause pancreatitis. It's one of the things medical students learn. But I'd say overall it's rare. And if I had a patient who developed pancreatitis after a transplant, you know, you sort of go through things with a very fine tooth comb to try and understand why.
Thank you for that. How does gallbladder removal affect PSC?
Well, I think we talked about this earlier. You know, all individuals with PSC should have an annual ultrasound scan, looking in particular at the gallbladder and for any polyps. So I don't think taking it away necessarily changes your natural history of PSC, but certainly the risk of any polyps which can grow, that obviously, you know, becomes negligible and is no longer an issue.
What is the recovery time after an ERCP?
So I think if one is having an ERCP for the very first time, at King's, because the ERCPs in an individual with PSC can be a little bit, I would say, what's the word, tricky. sometimes because it takes a little bit more finesse. We tend to keep our patients overnight. We give them a full general anesthetic. They're recovered in endoscopy. They stay the night. They have their antibiotics, which is very important. And it depends, what has been done. But I'd usually give yourself at least 2-3 days, maybe, to get over it. You can feel a little bit sore sometimes. If there has been some stretching, or sort of balloon dilatation, some individuals do afterwards sort of feel it, although in theory you can't. Individuals have described it time and time again. So, maybe take 2-3 days off, try and relax, not doing, too much around the house or heavy lifting, and then sort of ease yourself back into work.
Thank you for that. Next question. I had a DEXA scan, which was fine. However, since having PSC diagnosed, I've had a broken coccyx and a broken big toe. I'm 44 and haven't had any breakages since my childhood. My DEXA scan was done quite recently. Is there anything I should ask my GP or hepatologist to look at? Both breakages occurred after very mild bumps. Didn't have a big fall or an accident.
So I think this individual has highlighted the importance of having a DEXA scan, and I think anybody with chronic liver disease should have a DEXA scan, and then according to their sort of results, you can stratify them according to risk of osteoporosis, osteopenia, or evidence of having both or either, and then they tend to be repeated between 3 and 5 years. I think if that's normal, then that's reassuring. Vitamin D levels we would always check as well. We all tend to be vitamin D deficient in this country, and then again, chronic liver disease can add to that. So I think we certainly think to look at that in that instance, and then sort of see whether these are just one-offs as opposed to sort of any related to any other issues.
Okay, thank you. Next question. I have PSC and crossover of autoimmune hepatitis. I'll definitely have to have will I definitely have to have a transplant? I also have Crohn's, but managed well.
So I think that's sometimes the question there that Matt has written is a bit like, you get an MCQs. Whenever there's the word definitely, that's false, because there's no definites in life. I think with Matt, what I would say is it's about assessing the state of your PSC, and are there any indications for transplant, and also assessing the sort of autoimmune aspect as well. Is this response to your immunosuppression good? What's the sort of stage of your scarring or your fibrosis? And over a period of time, how are things changing? Are they staying the same? I think it's important that your IBD and your Crohn's is well controlled, because that impacts your liver. And I think it's about just engaging and talking to your team. But there's no definites in life, I would say. But it's just about sort of reassessing and assessing and seeing how things change over a period of time.
Okay. We have another mother asking a question. Son has only recently been diagnosed with PSC and is still having scans. His scarring has been identified as level 3. Is there anything that can let us know how long he's had this? His itch is quite bad at times, but we are waiting on his next appointment for treatment. He's only 20. She's put another question. Okay. He's only 21.
Okay. So I think, sometimes it is hard to know how long somebody has had an illness for. Obviously diseases progress at different rates, but I think it's about, again, understanding what symptoms her son has, and obviously itch is an issue there, and then sort of trying to manage that symptom. Now, I think, when even those with sort of, who'd be perhaps in a category with moderate scarring, it doesn't always necessarily mean that, well, the next step will be a transplant. And although we can't reverse the scarring, we know that in younger adults, they tend to sort of, carry on and cope a lot better than perhaps adults who are maybe 20 or 30 years older, because it tends to be less other illnesses. They tend to be more sort of physically replete and have sort of a better reserve. So I think it's about just trying to get the symptoms under control, in the first instance.
Great. Now I'm just going to put another request out there. If anybody's got any questions, please put them in the chat. We've got 4, I think, so far that we've got to come to. But if anybody's got any more, please put them in the chat. So this is a follow-on question from that mother. What support can we offer? Can we offer him, our son?
So I think support is in every sort of sense of the word. Sort of physical, psychological, emotional support. I think the team that is looking after that individual, it's hopefully a holistic approach as well. And I think in a 21-year-old, having the availability of a psychologist would probably be quite important. I think safe information that's available on the PSC support gives you an insight maybe into some of the symptoms people can experience, and also some of their anxieties and sort of worries over a period of time. And obviously they change as well. So for a 21-year-old, it might be very different to a 25 or a 30-year-old as well. And with anything, sometimes you're just there to listen and letting them sound off whatever sort of worries or issues that they want to discuss, really.
A question here about diet. What are your criteria for referral to a dietitian with knowledge of PSC?
So I think again, the availability of having a dietitian within the service is important. I think where they can certainly be of very sort of great importance if there's concurrent IBD as well. So usually it's where there's weight loss and it's unexplained, and trying to review that there's no sort of evidence of malabsorption related to, for example, the IBD or other causes of malabsorption. Again, in an ideal world, if we had access to dietitians all the time, and it's certainly something we struggle with at times at King's, we would have a dietitian embedded in the service, and anybody who wanted to see one could. But I think again, it's about resources and availability, unfortunately.
Okay, I think I keep saying put the questions in the chat. I mean, put them in the questions and the Q&A section. Chat is turned off. Somebody's just reminded me of that. I've got 3 different questions about supplements and drugs. So we'll take those. Next. I'm 100 kilograms. What is the recommended dose for Urso?
So the way we tend to dose Urso is between 13 and 15 milligrams per kilogram per day. So if you're 100 kilograms, you can split potentially maybe 1,500 in sort of divided doses. But that dosing is a sort of a safe dosage. So other studies where they've used much higher sort of dosing, so between 25 and 30 milligrams per kilogram per day, were associated with a lot of adverse events in a previous study. So I'd start with 13.13 or 15.15 milligrams per kilogram per day.
Okay, thank you for that. Is magnesium as a supplement safe and effective for chronic fatigue?
I don't prescribe magnesium for chronic fatigue. Magnesium supplements are prescribed to a lot of patients after transplant due to some of the medication that we give, which causes the individual to pee out their magnesium. So there's no harm in taking it, but I'm not sure about the efficacy for fatigue alone.
That's good to know. We don't want people wasting money on things that might not work. But if people want to take them and feel better, then obviously that's safe. Great. Okay. Last question on, well, there's another question just come in about medication, and this is not necessarily PSC related, but I'll ask you it anyway, and you can tell me if you want to answer it or can answer it. What is the new antibiotic that's being used for Crohn's disease?
So I'm wondering whether the individual is referring to vancomycin.
Okay.
So vancomycin, is an antibiotic. It's been used in different populations, I would say predominantly in sort of young adults and pediatrics, trying to treat PSC. There was a study recently again from Birmingham, which was published earlier this year at one of the the sort of IBD conferences of using vancomycin as well. So it's not mainline, it's not sort of routine practice, but it may be what the individual is referring to.
Okay, so another question. There's a question here about vancomycin.
Yeah.
How long have you seen a patient take vancomycin and respond well to it?
So again, in adults, I've never prescribed vancomycin for treatment of their PSC. I have certainly looked after sort of young adults and pediatric patients who've come through the system at King's who were prescribed vancomycin. And it tends to be anecdotal. So that one individual had been on it for 6 years and was good. But I suppose what we'll never know is, was it the vancomycin or not? Vancomycin in an oral dosing is usually quite safe. It's sort of excreted through the bowel. It doesn't tend to cause many side effects. And the doses tend to be quite low. So in theory, it sounds very good, but I think as a scientist, we would need hard data to show that if you gave 1,000 people this drug, it would do A, B, C, and these would be the benefits. And I think at the moment we just don't have enough data.
Yeah. Okay. So this question's about teeth, actually. As you previously mentioned, PSC can impact bone health. Is there a relationship with teeth? Since my transplant last year, I have seen a deterioration in my teeth.
It's a very interesting question, actually. I think after transplant, there's a lot more other variables. So, for example, steroids can sometimes impact sort of dental health as well. And if you've had a transplant, you certainly would have had high doses of steroids at the start, which then eventually wean down and can potentially stop. So I think we don't routinely look at dental sort of health or dental hygiene after a transplant. Certainly before a transplant, we always make sure that no individual who needs a transplant has sort of poor dentition because that needs to be rectified before a transplant.
Okay, thank you for that. My son's PSC has progressed significantly in 1 year. That's why he needs an ERCP. He's only 19. I presume that means there is no doubt he will at some point need a liver transplant.
So the indications for ERCP, don't always translate into a need for liver transplantation. So if you have a high-grade stricture or a stricture which needs to be treated, then that might be the indication for the ERCP. It might be that they've got a gallstone which is now formed and needs to come out as well. So I think it's important to understand the need or the indication for the ERCP and then how they respond to the ERCP as well. So it could be that there's worsening itch, there's a stricture which needs to be treated. After the stricture is treated at the ERCP, the itch disappears, and there's no need for a transplant. I think, again, when you have a young individual, you have a family member, a child, obviously the worry sometimes is that it may be that the disease is progressing. But again, I think it's about talking to your team, your consultant, and saying what has changed, after the ERCP, what sort of improvements are we looking for? And then what are the next steps? They can be, I'll be honest, they can be very difficult conversations sometimes because it's always there in the background. And for some people that, you can choose to put it away, hide it away. And when it comes to the forefront, it can be quite upsetting for everyone involved. But it's about communication and just talking through concerns and, of the patient, but also of the family as well.
Okay, next question. When and if are we likely to see new treatments to treat PSC? Difficult question to answer, I know.
Yeah, I think so. There are a number of studies which have now closed. So the Urso the noracid acid study has closed, I think perhaps over 6 months ago, if not longer, I can't remember. So, that data will be, be compiled, it'll be presented at a big conference, and then, we'll understand in which individuals potentially, if there's a positive signal, who do we use it in, and how do we sort of roll it out to individuals as well. So, I think as some of these studies close, it's about looking at the data, looking at the safety signals, and then seeing which individuals are likely to benefit. So there's a number of studies that have closed. So hopefully within the next, again, like I said, I'm an optimist or a positive individual. Maybe in the next sort of 12 to 18 months, there may be something which it will be licensed for PSC potentially, but let's see.
Yeah, I mean, that would be absolutely fantastic. That's all the questions that we have for you today, Dr. Joshi. Thanks very much to you, and thanks to everyone who's taken the time to join us and to ask those fantastic questions. I do hope it's answered them for you. I'm sure it has. So yeah, thank you everyone for joining us. Thank you, Dr. Joshi, for joining us. We hope you will join us again. Our next session, our next RC expert is on the 23rd of October at 1 o'clock. And that will be Dr. Palak Trivedi on research. I know people are very interested in that. They'll be very interested in that topic. So I'm sure we'll have a lot of people joining us on that day as well. So have a great month, and we will see you in October. But thank you so much, Dr. Joshi. Bye-bye.
My pleasure. Thank you, everyone. Have a good weekend.